Good afternoon, everyone, and welcome to the Womxn Project's Economic Justice Denied panel. We're going to be discussing abortion coverage and bans and Medicaid. And today, my lovely guests are Linda Katz, co-founder and policy director at the Economic Progress Institute, Senator Bridget Valverde from Senate District 35, East Greenwich, North Kingstown, South Kingstown, Narragansett, and then Rep. Liana Cassar from Barrington and Riverside for District 66. So I just want to say thank you all for joining me this afternoon. I know it's lunchtime and normally we're eating at this time, but we need to discuss something that's really, really important. So today we'll be discussing Medicaid and the abortion bans and the legislation that was introduced and how it will help the people of Rhode Island. No one should be denied access to abortion care because of how much money they have or what kind of insurance or what kind of health care that they have. The Medicaid program is meant to ensure affordable access to health care for low-income families. But the fact is, our state is taking benefits away from people who need abortion care and they need it the most. This panel of policy and Medicaid leaders will get you informed and ready to take action to address this injustice. So I just want to tell everyone a little bit about the Womxn Project and who we are and what we do. So we all know the previous administration was not the nicest. So when his, I don't want to say his success, or when he won the election, there was a group of people sitting at a table and they were angry and scared. And when people are scared and they're angry and they're trying to figure out where they need to go or what direction they need to take, great things happen. And thanks to the Hera Gallery, the first of many discussions started, and then it turned into this, I call it an island of misfits, because we are all from different backgrounds, different socioeconomic statuses, but we are all fighting for the same thing. And that's for reproductive justice and rights and access for everyone. So I am going to pass it on to Representative Cassar. How are you?
I am doing great, Jen. Thank you so much for the chance to speak on this panel today. I hope that everyone who's with us is doing well as possible amidst the impacts of the pandemic on all of our lives. And I appreciate that we're here to talk about economic justice and an important reproductive health issue. You know, often when we're talking about economic justice, we tend to focus on parental leave, equal pay, paid sick leave, raising the minimum wage, all of those things that are really obvious economic justice issues. And very often we leave out the healthcare portion of what economic justice means. But, you know, what's critical is that women are able to raise their children, develop their families, and all of our community members have the opportunity to move out of poverty. And so being able to determine when, if, or how you want to start a family or raise a family is really a crucial factor in economic stability. Again, economic stability for the individual, the families, and communities. The reality is, and we all know through living through COVID for a year, that our healthcare choices are governed by the health insurance that we have, period. Who we can go to for healthcare, what services we can access, what services will need to be paid out of pocket. Really, that is governed by our health insurance first and foremost. You know, if we don't have the insurance for it, we have run the risk of incurring excessive costs. Or we, like I think all of us do at some point, we forego a little bit of healthcare. I'll wait, I'll put it off. And that really changes the dynamic and ultimately changes the economic reality for how you manage any healthcare issue. But bottom line, abortion is healthcare, and access to abortion should not be met with any financial barriers. We don't have freedom of choice. We are not able to support reproductive choice and reproductive justice if there is a financial barrier. And that's why this is an economic justice issue. All Rhode Islanders really should have equal access to the health services that they need. without health insurance coverage for abortion, people in Rhode Island on our state health plans and people who are covered by Medicaid do not have access to abortion. The Equality in Abortion Coverage Act is first and foremost a health equity bill. The EACA aims to end discrimination in health coverage by ending the ban for the use of health insurance to reimburse providers for this basic reproductive health service. Currently, the state law bans health coverage for abortion for state employees and their families. That ends up impacting about 32,000 people, I believe. And federal law through the Hyde Amendment bans federal Medicaid dollars from covering abortion, which limits the access of people on Medicaid. People who are generally at the lower end of our economic spectrum, people with disabilities, individuals who are currently or formerly served by foster care, and a whole lot of other folks. So for those populations who already are encountering some disadvantages, we are piling on some economic injustice and the inability to have bodily autonomy and the autonomy to make reproductive health choices. So in order to understand more about this, I'm going to pass now the baton over to my colleague, Linda Katz, who is truly one of our outstanding experts in the state, who is going to provide a bit more information about the Medicaid piece of this. Linda?
Thank you, Rep. Cassar. And that was a great overview of why this bill is so important in connecting healthcare with economic justice and healthcare justice certainly go hand in hand. So I was asked to give an overview of the Medicaid program, which, I hope you're all ready to spend another 2 hours. I'm gonna do a very brief overview, and happy to do more. We also have materials on our website, economicprogressri.org. So let me just start. As Jennifer mentioned, the Medicaid program is designed to provide health insurance coverage to low-income people. It's interesting to note that Medicaid was adopted at the federal level at the same time as Medicare. And Medicare, as we all know, does not have an income test for eligibility. It's available to all seniors and to people with disabilities after a period of time. But the Medicaid program was adopted just for low-income people. These were both adopted in 1965. Medicaid is jointly funded by the federal government and the states, and each state operates its own Medicaid program within federal guidelines, but states have considerable flexibility in designing and administering their programs. So eligibility for the program and also the benefits vary widely from state to state. I'm happy to say in Rhode Island, we have pretty much since the beginning had fairly good broad eligibility and coverage of services. And I'll talk about that as we go through this. So originally, when Medicaid was enacted, it was only open to families, pregnant women, seniors, and people with disabilities. But with passage of the ACA in 2010, Medicaid was made available to low-income individuals without children between the ages of 19 and 64. And the intent in the ACA was to make Medicaid the foundational health insurance plan for all Americans, albeit with lower income. But that, unfortunately, was undermined by the Supreme Court ruling in 2012 that held that states were not required to offer coverage to this expansion population in order to continue to participate in the Medicaid program. So essentially, it became optional for states to provide coverage to that population. So let me talk a little bit about who's covered by Medicaid, what services are provided, and I want to touch on immigrant eligibility as well, because I think that's really important. And then I'll talk a little bit about the financing. So starting with the populations that are covered by Medicaid. In order for the state to participate in the program, they have to provide coverage to certain populations. So those are called the mandatory populations. Those are children through age 18 in families with income below 138% of the poverty level, pregnant individuals who have income also below 138, certain parents or caretaker relatives with very low income, most seniors and people with disabilities who receive cash assistance through the federal welfare program called Supplemental Security Income. And then states can cover what are called optional populations. So that would include the expansion population now, and it can also increase the eligibility limits for those mandatory populations. So for example, in Rhode Island, the current mandatory income limit for pregnant women is $24,000 a year for a single pregnant woman. In Rhode Island, our income limit is almost double that of $45,000 a year. And Rhode Island, as I mentioned, opted to cover the expansion population, and the income limit for a single adult is $17,774. And if you want to know the income limits for the other populations, for kids, for seniors and people with disabilities, you can find that on our website. So that's one, the mandatory populations. Now let's take a minute to look at services covered by Medicaid. So there are mandatory services, just as there are mandatory populations. The mandatory services include hospital and physician care, lab and x-ray, behavioral health services. There's coverage called EPSTT for kids, which basically mandates certain screening that has to be done for children, testing, and then treatment as conditions are identified, even if some of that treatment would not normally be covered by Medicaid. Family planning services and supplies, patient education and counseling on reproductive health, sterilization and abortion. But as Rep. Cassar already mentioned, abortion is only covered by Medicaid in limited cases of rape, incest, and life endangerment. But the abortion limitation is not part of the Medicaid law. It's again, as Rep. Cassar mentioned, a result of the Hyde Amendment, which blocked federal Medicaid funding for abortion starting in 1976. So that's actually just a rider on the funding for Medicaid. It's not part of the Medicaid statute, and I'm going to come back to talk about that in a little bit. The last mandatory service I want to mention is non-emergency medical transportation, which is really critical because that's a way that low-income people can get access to the healthcare services by having their transportation costs covered. And then, as there are optional populations, there are optional services. But when I read the three examples of optional services, you won't think that they really should be and in fact, Rhode Island covers these, and most states do. Prescription drugs, that's an optional service. A state could say, we're not covering meds anymore in the Medicaid program, and there would be no repercussions for that from the federal agency. Dental care is another optional service, and vision services. I'll just mention with dental care, one year when the state wanted to try to save money, it proposed eliminating dental services for adults. And there was such an outcry that the state did not wind up going through that. But it's a typical kind of thing when the state thinks it needs to cut costs in the Medicaid program to cut dental care. And then states can also request waivers to the federal Medicaid populations and services. And Rhode Island has been operating under a waiver for its whole program called an 1115 waiver for a very long time, which has had a lot of positive repercussions. In some ways, it was just a way to try to save some state dollars or capture some more federal dollars, I should say. But it also resulted in things like people who have asthma who are on Medicaid can actually have window replacement, or I'm sorry, where there's lead in homes, Medicaid can pay for window replacement in those homes to make the home safer. So that's covered population services. I want to touch on immigrant eligibility for a minute.
Linda, we lost you. You're something must have hit your microphone.
You okay now?
Yep, that's better.
All right. Okay. In 1996, Congress passed the Personal Responsibility and Work Opportunities Reconciliation Act, PERORA, which limited lawfully, and I emphasize lawfully present immigrants' eligibility for Medicaid and a host of other public benefits. One of the biggest impacts was to say that somebody who has a green card, a lawful permanent resident, could not get Medicaid and other public benefits until they had been in status for 5 years. So it was a 5-year waiting period. But it also banned some lawfully present immigrants from ever enrolling in Medicaid An example I'll use is Rhode Island has a fairly substantial population of people here from Liberia who came to this country because of the Civil War in 1991. And they were granted what's called temporary protected status, or TPS. So they're legally here, they have authorization to work. They were eligible for Medicaid until PERORA. And then when PERORA went into effect, they became forever ineligible for Medicaid. And undocumented people, people who came in and maybe overstayed a visa or walked across the border, they have never been eligible for Medicaid or other public benefits. But there is protection for pregnant women. So Rhode Island was a leader really in saying that all pregnant women should have access to health insurance coverage so that they would have healthy births. That was under the leadership of the Department of Health back in 1993. We started to cover all pregnant women regardless of status. And originally, because the federal government did not allow us to claim federal payment for some of those women, undocumented, some in temporary status, Rhode Island used state-only funds. So think about, as we're now looking to have Rhode Island use state-only funds for abortion, we have a history of doing that to accomplish certain public policy goals, especially related to healthcare. So we covered undocumented women and others who didn't meet the federal eligibility definition. Then in 2009, Congress authorized states to claim federal funds for lawfully present children in the Medicaid program. And Rhode Island had covered all children for a while, stopped, but then resumed when the federal funds became available, and also to claim federal funds for pregnant women, regardless of status. Actually, the state is covering the unborn child, or as I call it, the pre-citizen. I think we can have some concerns about the state maximizing federal payment by using this funding stream as we're covering the unborn child. But that's what we do now in Rhode Island and many other states as well. So next topic briefly is, how is Medicaid funded? We all know that Medicaid is a pretty large ticket item in our state budget. It's about $2.5 billion, but that's the federal and state funds all together. And a lot of that is coming from federal funds. So let me just talk about that for a minute. The share of the cost covered by the federal government is called the Federal Matching Assistance Percentage, or FMAP. FMAP is computed from a formula that takes into account the average per capita income for each state relative to the national average, but it can be no lower than 50%. Rhode Island's FMAP has been just over 50% to about 54% over the past 5 years. But then Congress has used the FMAP as an incentive to get states to cover more of its residents. So for example, in 1997, when Congress wanted states to cover more children with higher income, it raised the FMAP for this population under the CHIP program, the Children's Health Insurance Program. And that induced many states, because they were going to get a higher cost share from the federal government, to increase the income limit for kids. And the most dramatic example of this is with the ACA and the expansion population, right? The federal government knew, it intended that all states were going to cover all 19 to 64-year-olds with lower incomes. And it understood that that would be a big financial lift for the states. So for the first couple of years, the federal government paid 100% of the cost for covering that expansion population. That decreased to 90% over time, but it remains at 90% going forward. So for the 9,000 or so expansion population folks that have a Medicaid card, the state is getting 90% federal cost sharing for that population. And then because of COVID and the increased costs of care and the increased number of people who were turning to the Medicaid program as they lost their commercial health insurance, Congress, under the Corona Aid, Relief, and Economic Security Act increased the FMAP to states. So right now in Rhode Island, we're getting a 61.8% FMAP, higher than our usual 50 to 54%. So for every dollar that we spend on the Medicaid program, we receive just under $1.62 from the federal government, and then even higher amounts for the CHIP population and for the expansion population. Okay, so that's the money piece. Let's look a little bit at Medicaid in Rhode Island. We currently are covering about 325,000 Rhode Islanders in our Medicaid program, and that's both healthcare and long-term care services. 51% of those 325,000 are children, parents, and pregnant women. 28% are in the expansion population, the 19 to 64-year-olds. About 16% are those who are 65 and older or under age 65 and have a serious disability. 3% are children with special healthcare needs, and 1% are in foster care or post-foster care. And then if we drill down to women of childbearing age between the ages of 15 and 45, about 48,000 participants in right care are in that age, women are in that age bracket, 23,600 in the expansion, for a total of about 72,000 women in that childbearing age range, and another 5,000 or so women with disabilities and in substitute care. The second question I was asked to talk about was, how does providing coverage through Medicaid help to address health disparities and get people out of the cycle of poverty? First, because racism and discriminatory public policies have created systemic and economic barriers that make Black and Latino women more likely to be low income, they are more likely to have Medicaid as their source of health insurance coverage. So just looking at women of childbearing age, and this is a national number, approximately 30% of Black women, 24% of Latino women, and 14% of white women are enrolled in the Medicaid program. And the Medicaid expansion has given an opportunity to see what happens when Medicaid is available and when it's not, because unfortunately not all states have taken advantage of having expanding coverage. So there have been a number of studies to look at how has Medicaid expansion helped, and it's shown that Medicaid expansion has helped Black and Latinx people gain coverage, as well as with that insurance has come improvement in health outcomes. So the one example of how Medicaid expansion has helped improve outcomes is that a study showed that expansion was associated with lower maternal mortality and helped address the existing disparities for women of color. The study found that among all women, Medicaid expansion was associated with, was in one state, 7 fewer maternal deaths per 100,000 live births. Black women experienced 16 fewer deaths per 100,000 live births, compared to 6 fewer among Hispanic women and 4 fewer among white women. So we know that there has been, as Medicaid has expanded, more people have access coverage, more people of color have access coverage, and health outcomes are starting to improve. So I just want to close my part of the presentation by referencing the Supreme Court case that really brought home to me the institutional ignorance about poverty and impact on people's lives. And I think also goes to the point that Rep. Cassar has been putting forward about the need for economic justice through health justice. So people may know of the case Harris versus McRae, which was decided in 1980. It was a 6-3 decision by the Supreme Court in a case brought by what in the case were called indigent women, asserting that states that participated in the Medicaid program were required to provide abortion services, despite the Hyde Amendment, which provided that federal funds could not be used except for very limited circumstances. The court decided that states were not constitutionally required to cover all abortion services, and part of the rationale depressed and angered me, and still does. So I'm just going to quote from the court that although a woman has a right to have an abortion, it does not follow that a woman's freedom of choice carries with it a constitutional amendment, constitutional entitlement to the financial resources to avail herself of the full range of protected choices. Although government may not place obstacles in the path of a woman's exercise of her freedom of choice, it need not remove those of its own creation, and indigency falls within the latter category. Thank you.
That was a lot. Most people don't understand how Medicaid works anyway, so thank you for explaining that. There's a huge misconception about the funding and how the tax dollars are spent, so thank you. I do have some questions for you, but I will save them to the end. I'm going to pass it on to Senator Valverde so we can talk about the cost benefit of abortion coverage and how it will help to save money. So, Senator.
Thank you, Linda, for that great overview of Medicaid. As Jennifer said, it is a misunderstood program, and so having that background is really great. So I just wanted to start my comments with kind of an acknowledgement that these bans that we are talking about for abortion coverage, both for state employee health insurance plans and for people covered by Medicaid, are not an accident. They are bans that are brought about by anti-choice politicians who, would like to see no abortions happen, but instead are, wielding the power that they have over low-income women and other populations, in a way that they can to sort of prevent as many abortions as they can, while, but the effects of that are causing economic harm. And so, we are, yes, economic justice issue, it is a health equity issue. It is, this is really, I think, a violation of rights for women, across the country. So as Linda talked about, Medicaid covers, low-income populations. And so the ban on abortion coverage has a compounding effect on people who are already at an economic disadvantage. It's really an extension of the barriers that already exist to getting care for these people. And barriers to accessing the full range of healthcare, including reproductive care. And so that means that people who are struggling the most, often women of color, are told that when they need an abortion, they have to either pull together what little funds they may have, or forego things like grocery money, paying their rent, and attending to other financial needs. Or they have to continue with a pregnancy that they, may not be able to afford. Studies have shown that 60% of women who seek an abortion already have at least one child. So that means that, these bans are affecting, not only the individual person who may not be able to access an abortion due to lack of coverage, but it's also their, their families, their children, and that affects their entire economic future. So this really long-term effects, economic effects on women. When women are forced to carry an unintended pregnancy to term because of lack of funds or coverage, they're 3 times more likely to fall below the federal poverty level within 2 years. So, this idea that people are being denied abortion, they are, their families are affected for years to come. And these economic injustices don't just affect the pregnant people. It causes economic harm to all of us. Women who face these barriers to care are more likely to leave the workforce. So we are missing out on economic prosperity, as a state and as a country because of these bans. They're saying that they're likely to leave the workforce because of lack of affordable childcare, which as we know is another huge problem that we're facing. And 3/4 of women who have had an abortion say that the cost of having a child would have rendered them unable to fulfill responsibilities to care for dependents, go to work, or attend school. And so, we all know that we're facing these care crises for childcare and for elder care. And so, forcing women to carry unintended pregnancies to term just is only making these problems worse and worse. Let's see. So, I talk about education for a minute. We've got women who are unable to finish high school, are unable to pursue other educational opportunities. Again, that is their future economic outlook is just taking a hit, again and again for them and for their families. People deserve to have the access to a full range of reproductive care, no matter, what their insurance is or what their income level is. And so playing politics with people's lives, people's economic futures, it just cannot continue. And so that's what we're seeking to do with the Equality and Abortion Coverage Act, is to, it's a small, relatively small, but very critical piece to making sure that the economic futures of all Rhode Islanders are secure, especially as we are looking to, kind of rebuild after this economic crisis that we're in right now due to the COVID pandemic. It's more important than ever that we pass this legislation and take away these barriers to care.
Thank you. Thank you. So I'm going to open all of this up for a discussion. I do have one question. Actually, I have a few. My biggest thing is, I know in certain states, you can have state covered insurance and it does cover abortion services. I know for certain people it has happened. And I'm just wondering, is there something different that we're missing that other states know about, or does anyone know, or can anyone explain the barriers that we're facing here in Rhode Island compared to other states and why we can't do that? I know it's kind of all over the place, but I know people in Massachusetts who have what they call Mass Health, which is a state insurance, and it covers abortion services. So I was just wondering if that was something that we could do in Rhode Island to expand for those people who really do need it. Whoever wants to answer.
Sure, I will go. So, yes, there are various states that cover, whose Medicaid programs do cover abortion, as well as, their state health insurance plans. We are surrounded by states that cover these services. I believe Connecticut, Massachusetts, they both cover abortion care. There are other states who have been, their states have been forced to cover abortion care through court injunctions, and so there really is no reason why Rhode Island should not cover these services through state Medicaid dollars, through our state health insurance plans. It does not cost more money. It is. It makes economic sense for all people involved.
Did you want to discuss how state employees who think that they have abortion coverage on their insurance don't really have it, and how they found out?
Sure. So I can speak for myself. As a state legislator, I am technically a state employee, and I was shocked to learn that the coverage that I have, that my family has, through the state, does not cover abortion. And I'm sure it does come as a shock to, to many, people who may find themselves, pregnant with an unintended pregnancy, that they don't actually have coverage for abortion care. It's not something that is, when you sign up for your health insurance with a new job, that, you get a little piece of paper that says, just so you know, you don't have abortion care. So I think it is shocking. And I think that it's really important that we, talk about this in forums like this, so that more people can know that, we are we do have discrimination just written into our state law, literally written into our state law to deny people care.
I think
And-
that's also a concern when it comes to providers, right? It doesn't only impact us as individuals seeking care, but it also impacts our provider community, because there may be a need for a referral or a provider who just wants to be able to discuss all of the options that are available to a patient, but then finds that there's an economic barrier as well. And so I think when we look at this, we very often think we're talking about a single individual, but it impacts families, it impacts the healthcare system, it impacts services. I think that it becomes more of a navigating challenge for providers who want to be able to provide referrals, but are finding limitations as a result of the health insurance, as opposed to the availability of services.
Right. And I just wanted to clarify, I know that I provided a lot of information about the Medicaid program. I just wanted to make clear that, there's no bar for Rhode Island to use its own dollars, our tax dollars, right, that we all pay in, to make sure that there's equity and access to care, and to say that a person who is enrolled in the Medicaid program will have access to abortion coverage. It will not impact our ability to continue to get federal funding for the rest of the program, right? It just means that we're using our state-only funds to ensure that there's access to all necessary services for people who are enrolled.
Thank you. Thank you for that answer. I do have a question. How can we better support this legislation? What can we do to bring people together to make sure it passes? Because we need this. I don't know who wants to go first.
Yeah, it's raising awareness. Outreach is always good. Legislators need to hear from their constituents to understand what the priorities are. And, when you talk to the general public, we are a state that believes it's predominantly left-leaning and whatnot. And this is a basic tenet of the platform of those who believe in more progressive and liberal ideas. Women's rights, women's, reproductive freedom, reproductive justice seem like, at least for, this is something I've been working on since I was in college. So it seems like it's been a very obvious part of the platform forever, but I don't know that a lot of Rhode Islanders realize that they need to check in with their legislators, find out, where do you stand, ask specifically, encourage, make the case in case if your legislator doesn't have an opinion or hasn't formed a decision about how they would vote, help inform them. I think that's critical. Outreach to the legislators who are going to be voting on these pieces of legislation.
And I'll just add that, while the bills are there, and I am so glad that Liana and Bridget have submitted the legislation, ultimately, the decision on whether or not this moves forward will be part of a budget decision, because since this impacts state funds, both to expand access to women on Medicaid and to expand access for state employees, those budget negotiations are where decisions will be made about whether the bills are passed. They'll be passed as part of the budget. So, the people's voices to their legislators is really important. I think that often people think it's a scary thing to call your legislator, or, but pick up the phone and do it. And that's, having done advocacy for a long time at the State House, it's building awareness. People may not know that abortion services are not covered. And B, once people do hear, if they're concerned about that, they should just call their state rep and state senator. They can find information on the website and at the Secretary of State's office. If they don't know who their senator and representatives are, pick up the phone and make a call.
Mhm.
Absolutely.
Do you think that when people share their own personal stories and how the expansion could help or the coverage could help, do you think that would help to push the legislation through? Like, should people write down in written testimony and say, hey, this is how it would benefit my life, or how this in the past has affected my life, do you think that would help?
Absolutely. I think any perspective on any issue really is, a personal perspective on things always helps. And I'm glad that you brought up written testimony, because these bills will get a hearing both in the House and in the Senate. And the public always has an opportunity to come and testify. You don't have to be any sort of professional in a field in order to testify. You can, be any private person and come and testify. And, this year things are looking a little bit different because our state house is closed to the public. So we are holding our hearings remotely, which could also be a good thing. More people, can have access that way. So you can submit written testimony. You can also sign up to give testimony over the phone, live directly to the committee when the bill is being heard. And I would encourage everyone who cares about this issue, who cares about health equity, who cares about economic justice, to weigh in on these bills.
I will say, I think people forget that having the proper health insurance is really, it's intersectional, because it affects everything in your everyday life. If I don't have the right health insurance, I'm going to go to work sick, or I'm not going to be able to go to work because I'm too sick and I can't go to the doctor because I can't afford it because I missed work. And it's a cycle that never continues. And they always say when people have the proper health insurance coverage, they are happier because it's less for them to worry about. And I think that's something that people continue to forget about. Like, when you have the services or access to the services that you need, your life tends to be happier, and your level of, I always say happiness, it just increases because there's less stress on you. So,
yeah. I think Bridget made a comment earlier that talked about the compounding effect of disadvantage. And I think that's what you're talking about. But I want us to always remember there's the compounding effect of advantage, that when it is clear, that when I don't have to question, when I don't have to worry, then I can sign up, I can sign up for services. I can have preventive services. I can call when I have a question before there's a significant problem. It ends up costing less, right? If I know that birth control is covered, then I can take the step to prevent an unplanned pregnancy, or I can go for a consult. There's the compounding effect of advantage of having good health insurance, of having coverage that prevents problems as well.
thank you. Did anyone want to share any final thoughts or ask any questions to each other? Or I'm going to open it up to you.
I think it's just such a good reminder, Linda. Thank you for the overview of the mandatory pieces of Medicaid, because I often forget kind of the population's, piece of that and the services piece. So, and how much already gets covered, and how close we are, and to carve out one piece, that we have this one important sort of high impact service on a life that we just carved out of that and put to the side, unnecessarily so, disadvantaging people more. That was really resonant for me as you were talking about the mandatory elements.
Mm-hmm.
I'm sorry. Go ahead,
Sonia. I would just like to, remind people that, 2 years ago, we passed the Reproductive Privacy Act, which really, the General Assembly, and along with the governor's signature, we affirmed as a state that people have the right to an abortion. And so this, with the bill, with the Equality and Abortion Coverage Act, we are just trying to make sure that right can be realized by everybody who wants to take advantage of it. Because right now that is not the case.
Right.
Yeah.
Absolutely.
I will say that I did learn something new. It broke my heart, the optional services about dental care. I don't think people realize that your oral care is very important in your everyday life. And to know that that's something that's optional is really, it's sad. It's really sad and disheartening. So Thank you for sharing that, Linda.
I mean, I think it's a longer discussion for another day, but the kind of the separation of oral care is not like regular covered health care is like a huge problem in my mind. You
Yeah.
Same.
We could
know?
go on for days about this.
Yes.
Right. When we overcome that hurdle, I will be so excited. The idea that this is actually part of the whole body.
Yes.
Radical.
Yep, dental, mental, and physical, it's all one,
Yes,
right?
all one. It is
And,
all.
Really is.
you know, we also have a long way to go just to make healthcare available to everybody. You know, the discussions about universal coverage that got highlighted during the presidential debates is really important to keep going. You know, we've been expanding coverage incrementally, and you're right, Rep. Cassar, you know, leaving out this one service. But I also think about how we've just got a long way to go. And look forward to continuing to work with everybody to make sure that everybody has access to the healthcare that they need. That's at, you know, at a price that they can afford. That's really the bottom line.
Yeah. Timely, quality, affordable care. That's it.
Right.
That's
Yep.
all.
I just want to say thank you to the three of you for joining us today. I know Wednesday is Abortion Provider Appreciation Day, so we're going to have another panel to discuss how we can advance health equity by improving abortion access. So that panel is happening on Wednesday at the same time. And to those that are watching, please, we are strictly volunteer run. We all have other jobs that we have on a daily basis, and we are working extremely hard to try and make sure that the people in Rhode Island have access to the services that they need, that we need. So please feel free to donate $5 if you go to the womenproject.org. It's not an E in women, it's an X. And $5 goes a long way. And to those watching, please reach out to your legislators and ask them to support these bills because we really need it. The people of Rhode Island really need it. People should be able to make the decision on their own as to whether or not they want to start a family or continue being a pregnant person. So I just want to thank the three of you so very much for joining me today.
Absolutely.
Thank you,
Thanks.
Jennifer.
Thank you.
Yeah.
We'll talk to you all soon.
All
Stay
right.
safe. Please stay safe, stay healthy.
Thanks. You too. Take care, everyone.